Stanford University.
Thanks. Thank you very much. Thanks for inviting me. Thank you all for coming to my mini class without quizzes. Although I want you to quiz me, so I'm going to try to leave plenty of time for question and answer at the end. As was mentioned, I was a graduate student here at Stanford, and at that time, there was really almost nothing existing in the field of medical robotics. The idea that you would use a robot to do surgery or rehabilitation, well, let alone drive a car by itself, was pretty questionable at that time, about 20 years ago when I started graduate school. However, the field of robotics has really grown in that time, and both their ability to operate autonomously and also connect with humans, whether the humans are recipients of care in some way or the humans are controlling the robot and using the robot as a tool, that has just increased exponentially over the last decade or so. So I'll be specifically talking today about medical robotics and trying to give you some information about what is the technology that lies behind these devices and what are the applications, where are they useful. And I had a request to also address things about cost and some societal impact. If I miss those in my main talk, I'm really looking forward to your questions about some of those bigger picture issues. All right, so kicking off to talk about medical robotics, I'm going to start with just an introduction quickly to why robotics are useful in medicine. Why would you even want this? Is this a good idea? And then talk about a few different examples of research projects that we've done in our lab, many of which have been connected to industry and will hopefully have an impact on patient care someday, including steerable needles, robot-assisted surgery. This is with the Vinci surgical system, which is a very popular existing commercial robot, and also some research where we use robotics to help give us some insight into the functioning of the human brain, especially when there are deficits after stroke and other problems. So to start with, why medical robots? Well, compared to people, robots have some advantages. They're very precise, they're untiring, they don't get tremor if they're programmed correctly, especially not after several cups of coffee. And as long as they are plugged into the wall, as long as you have a power source, they're untiring. So clearly there's been a lot of issues in medical practice lately with how much time people spend training and how many hours they spend, say, in the operating room. And this is a big challenge for the field because we obviously don't want to kill these folks by overworking them or decrease their performance by overworking them. And yet we need ways of making healthcare more efficient. I'm not saying for sure that robots yet are making healthcare more efficient, but the opportunity is there. So on the technical side, robots can be smaller or larger than people, and this can be an advantage in several ways. So the picture shown over here shows a surgeon's hand, which has a scale on the order of about 10 centimeters. And then this is the end point of a robotic manipulator that can go inside the body through a very small hole, and it has an endpoint distance of about 1 centimeter. And so you can see the scale is much smaller. So potentially it could allow you to do manipulations on a smaller scale. It can also let you get into the body through a smaller hole. And making procedures more minimally invasive is one way in which we hope to improve patient recovery and decrease the time that people spend in the hospital. You sometimes want robots that are actually larger than people. So there are physical therapists and occupational therapists that actually, they're healthcare workers, and they develop their own health problems because they do things like support the weight of a patient who is relearning how to walk after stroke. And so sometimes you want the increased size and power of a robot, being very careful to make it safe, of course, to be able to do things like support patients that are difficult for humans to do. Another part of robotics is that they can be remotely operated. Potentially they could be autonomously operated, but myself, I'm not so interested in autonomous systems, and I'm more interested in robots and humans and how they can work together. So one way in which they can work together is you could theoretically have a surgeon, say, sitting in New York and a patient in San Francisco, and the surgeon is actually remotely teleoperating that robot in San Francisco. And that kind of remote operation is really not a practical thing today, because how would you actually handle that communication line? If you think about the reliability of your cell phone signal or your internet, I don't want a robot operating on me, over that signal. It's just not reliable enough. So what is actually happening today is robots are remotely operated, but they're in the same operating room as the surgeon. So the surgeon sits at a master console. It's almost like the surgeon's playing a video game. I'll show a picture of one later. And they're manipulating these fancy joysticks. The robot, however, because it's smaller in size, it has a smaller scale, it needs to be remotely operated by the human, so the human is effectively controlling the robot inside the body of the patient without the human operator having to actually be inside the patient. So that remote operation is useful even when the robot and the surgeon sit in the same operating room. It doesn't necessarily have to be, a continent away. Finally, robots are connected to computers, which gives them access to information. Now, I'm a mechanical engineer by training, so I love the gadgets. I love the mechanical aspect of it. But what I really know is that there is a lot of computer science in this that makes it work. Because medical images, for example, are a huge, rich source of data about patients. You might have an MRI scan or a CAT scan that gives the surgeon all sorts of geometrical information about what's going on inside the patient. And while surgeons and interventional radiologists can do amazing things with that information, it's not as quantitative as the way in which a robot might be able to use that information. So for example, a robot can say, well, based on this image, I know that here's a delicate organ which I should not touch. And it can basically create a virtual no-fly zone, a boundary around that organ, and the robot won't go in there. And so this sort of information can be useful just for creating safety regions. Of course, a lot of people are thinking that these can make the robots autonomous eventually. But addressing this last point, the disadvantage of robots, or a limitation of them, I guess, is that they're really not able to operate in really complex, uncertain environments. Now, you might say, wow, we have Google self-driving cars. I actually live in Mountain View, and the Google self-driving cars are always all over my neighborhood. I almost feel like they're stalking me. My kids have created a game of like how many Google self-driving cars they see every day. And that's a pretty amazing feat. That is a huge contribution for robotics. But the roads, they have rules. There's rules of driving, there are laws, there are lights. That sort of environment, it's actually well constructed. A driving environment is well constructed to have autonomous systems figuring out what the rules are. Now, there are really iffy, complicated situations that might come into play when there's an accident or construction, and those are difficult situations still for self-driving cars. And right now, the thought is the solution will be you would hand over control to a human operator. Now, if you think about the complexity of driving and now go inside the messiness and the variability of the human body, every patient is so different. And even me, after working in medical robotics, I have no medical training myself. And I'll work with a clinician who will look at a medical image, like an ultrasound image, and he'll say, oh, that's that. Or you look at an ultrasound of your child or grandchild, and it's very difficult to recognize things. There's a lot of really important training and procedural knowledge that goes into medical training that robots just don't have access to that sort of artificial intelligence yet. And so in the systems that I work in, I'm very interested in how do you bring the human in the loop? How do you connect the robot and the expert together to treat the patient in the most effective and safe way possible? So these are the advantages and difficulties of robots. The big picture of what we try to do in my research lab is have robot-assisted interventions that are really going to improve patient care. And the way in which I think robots can do this most effectively is by following some of these tenets. So the first one is quantitative descriptions of patient state. A robot doesn't deal well with uncertain information. And so a robot has to have access to data in order to be able to decide how to perform. So that means that it has to know something about what the patient is like. And if you're doing a surgical procedure, maybe that means knowing something about the tissue mechanical properties. Or if you're doing a rehabilitation scenario, maybe that's some kind of model of the deficit in movement control that a patient has. The cool thing about a robot, though, is it can actually acquire that data. The robot has sensors on it, and it can actually start acquiring that information and building those models in ways that can be difficult for people to do. And then it can use those models to actually help plan an intervention. That is, again, all parts of medical robotics here. We're talking about the whole range. So the intervention might be, where do I target the tumor, or how should the person move to help them rehabilitate after stroke? And then comes the robot itself. And for me, the definition of robotics isn't some specific gadget, but it's the idea that you design devices, control systems, and processes that connect the information from these first two bullet points to some physical action in the world. And to me, that's a robot. I think of robots as basically the arms of computers. They allow that computed information to result in a physical action on the world. And then, as I mentioned, I'm very interested in how you incorporate human input in a natural way into these systems. And ultimately, our goal is to improve human health and quality of life. So I'm going to start now with talking about some of these individual projects to give you a flavor of the breadth of what's going on in medical robotics and what some of the challenges still are. So this first project is about needle steering. So needles are awesome medical instruments because they can get into your body in a very minimally invasive fashion. When you pull a needle out, it's a self-healing wound. You put a Band-Aid over it. You typically, don't have to suture. You don't have to worry as much about infection, and the recovery time from a needle poke is relatively short. But you can't always get to where you want to go with needles. So here's an example of a needle going in, trying to avoid these obstacles. But if you have a target here, like let's say a tumor, where you would like to deliver a cancer, a drug that addresses cancer, or maybe you kind of cook the tissue with something you put through the needle so that you can kill cancer, it's not going to be able to always reach the target with a typical straight line path. So what we would like to do is design needles that can actually redirect their motion inside the tissue. So it might go to the target. Maybe you don't want to pull the needle out all the way before going to another target. Oops. And so you'd like to be able to do this sort of redirecting, retargeting inside the body without having to pull the needle out. And just to give an example, which is a very common medical procedure, so for prostate cancer, one of the treatments that is used is called prostate brachytherapy. And the way that works is brachytherapy is the idea that you insert little radioactive seeds into tissue, and that radioactivity will actually effectively kill the cancer. And so in prostate brachytherapy, these interventional radiologists, or maybe it's a radiation oncologist, will insert needles through the perineum, which is basically the skin under there. And the needle will go through some skin and tissue and then finally target the prostate. And then you will leave a radioactive seed that gets pushed out through the needle. You pull the needle out, and then you put a new needle in to get to a new target. And the way in which the clinicians actually figure out where to put the needle is there's a template. It's a little block of material with a bunch of holes in it. And the columns are labeled A through Z, and the rows are labeled 1 through 10. And it's kind of like playing Battleship. They say, if I'm supposed to put a seed right here, go to F6. And then they put the needle in there, and they drop off the radioactive seed, and then they put a needle in. But some prostate brachytherapy procedures can involve 30 to 50 different needle insertions. So never mind the pain that might cause and the amount of time, but as the more and more needles are put in, the tissue will actually swell. You get edema or swelling, and that actually changes the treatment plan. If there was some medical image that was used a priori to say, these are where I want to put my radioactive seeds, once you have that swelling, things move around, and you don't actually know what your plan was anymore. And so all these multiple needle insertions can be a really big problem, which is why we would like to just put the needle in once, redirect, and try to be as efficient as possible in placing things like radioactive seeds. All right, so how do we actually get needles to steer inside tissue? Well, over the years, this has been a problem of interest to a lot of people in the field of robotics and medicine. And some folks have developed these very complicated mechanisms, which are basically like little robot arms with lots of linkages that can kind of do that sort of curvy steering motion. The problem with that is that they have to get pretty big inherently because of the mechanisms involved. And so we were interested in, could you do this in a very, very simple way? And so what we do is we use the asymmetric tip of a needle to actually generate steering, and I'll tell you how that happens. So here's a few different types of needle tips, just so you can see the difference between a classic cone tip needle, which is symmetric, versus the classic bevel tip needle, versus a needle where we actually actively pre-bend the tip, which is something that actually clinicians will do to help them attempt to steer needles by hand. So we use the tip asymmetry, so we don't use the symmetric tip needles, and this is the way it works. There's a robot out here whose only job, it's actually not shown in this picture, but I'll show a video in a little bit. The only job of that robot is to push the needle in and actually spin the needle about its long axis. And what happens when there's an asymmetric tip like this bevel tip is you can see the forces on the needle tip are at an angle. And what that means is that as the needle gets pushed into tissue, those asymmetric forces, which we teach about in undergraduate mechanical engineering, result in the needle actually curving as it gets pushed inside the tissue, because there's net forces pushing the needle up that way. And then you can spin the needle about its own axis. And if the needle is made out of a very flexible material, we use a super elastic material called nitinol, you can spin the needle about its own axis, just spin it around like this, and it will stay inside the tissue in the same location. And then you can insert again, and now because you've reoriented that bevel tip, it actually curves the other direction. So you can imagine that if you're putting a needle in here, and you have a target here, and there's an obstacle here, you could actually steer around it. And we're doing that without any complicated mechanism, potentially not biocompatible mechanism going inside the body. It's just a simple alloy material which is going inside the body, which is biocompatible. So just to give some more insight into this, the needle itself, like I said, it's this super elastic material. So in a minute, it'll show my grad student kind of showing how flexible this needle is. It doesn't deform permanently when you do that. It just snaps right back to straight, as shown there. And then as the needle gets pushed in, the shaft of the needle actually follows the tip. And what's interesting about this for me as a roboticist, if you think, okay, well, we're using a robot to insert, but it's interesting in robotics for more than that reason. And that is that it uses what's called a non-holonomic bicycle model. So what does that mean? Well, there are a lot of little mobile robots that have wheels that kind of run around on the floor. And they have this property that, like cars, they are non-holonomic. And what that means mathematically is that they can't move in any arbitrary direction at any time. So imagine you're parallel parking a car, right? I would love it if parallel parking a car, I could just move sideways into the space, right? That would be the best way. Maybe that's what actually that's probably the #1 application of self-driving cars first. There are actually cars that already exist that can parallel park for you. If I make enough money one day, I will buy one of those because I hate parallel parking. But instead you have to steer into place, right? So you have to step on the gas and turn the wheel in just the right pattern to allow yourself to steer into place. And that's because a car has the same system property that you can't move arbitrarily to the side. You have to steer if you want to get somewhere. And so like these mobile robots and like cars that are being parallel parked, these needles, you can think of them as steerable in the sense that you can never move them arbitrarily in any direction, but you can steer them in the right way in order to get to a target. And for me, that creates interesting robotics challenges. And we like to think of our needles actually as bicycles, where you can turn the front wheel, and that's sort of like spinning the needle around, and then it will go in these kind of constant curvature arcs, which is what would happen if you're parallel parking a car locally or driving a bicycle. And so when you do this, you can get all sorts of different curvy paths. And I want to actually see if any of you guys can figure this out. So these needles, because they have these constant bend or asymmetry in the tip, they always want to curve. So how do you think we make the needle go straight? Yeah, you just spin it continuously. So you can also spin the needle continuously, and then it will go straight. So every needle tissue combination is going to have its sort of maximum curvature that depends on the mechanics of the system, but its minimum curvature is always to be able to go straight. And so anywhere between straight and some maximum curvature, you can bend the needle. All right, so we have systems that do this. This example here we like to show because it's clear, but it's not exactly a medical application. Here we just have regular optical cameras looking down at artificial tissue, but we've also used fluoroscopy, which is X-ray, and 3D ultrasound images as well. And here is actually a video of the needle. It's not changed in speed or doctored up in any way, but that also makes it not super clear. So the robot is actually back here pushing the needle in and out and also spinning the needle about its shaft. So there's a motor here that spins occasionally. And then in light gray, because it's sort of embedded in the tissue, the artificial tissue, so it's hard to see, there's a needle that's coming in and out and hitting different targets and coming back to near the surface. And so that's the robot itself. So an interesting part of this, in addition to figuring out the imaging and figuring out the robot itself, is how do you actually plan the procedure? How do you actually figure out where the needle should go? And that can be very complicated, and more than anything, it becomes complicated because you can't always predict what the mechanics of the environment are going to be. You don't necessarily know before you put this in a patient what their particular tissue properties are going to be. So you can do planning, and you can say, well, if I want to hit a target here, this is an option, and this is an option, and you need ways of figuring out what is probably the best path to go. So actually, out of these two examples, it's kind of interesting. It depends what your objective is. If your objective is to have the shortest insertion possible, this is probably the best path because this yellow line is shorter than the other yellow line. However, if you think that these gray things are obstacles and you don't want to hit them, like I said, we don't always know what the tissue properties are in advance, so it might be dangerous to have a plan that actually gets you this close to something that you don't want to touch. And so maybe this is actually the better path, even though it's longer, because it's safer. All right, so the planning is a very interesting part of it. Let's skip that. And what I'm going to show now is a couple of videos of needles actually steering, in this case, an artificial tissue, and going around some obstacles to hit a target. And this version is actually completely autonomous, although our systems that are being tested in animal studies right now are actually teleoperated by the clinician. And we'll get more into teleoperation in the next part. So what you're going to see, these two images here are going to be replaced by videos. Basically, they are doing a very similar thing. This one is starting here. This one is starting over here. There's the target, and there's the target. It's actually the same target. But because of the slightly different starting locations, it creates a different plan for the path. One goes under the obstacle, and the other one goes over the obstacle. So I'll just show the video of the needles actually going in. So the darker one is the needle actually going in real time. And this is the actual speed at which the needles get inserted. You can actually see that this one over here isn't following the preoperative plan very well because our preoperative plan had errors in it. The actual tissue properties differed from the ones that we thought they would be when we started. But both of them still managed to reach the target based on replanning and using images to correct the ongoing motion. All right, so that's kind of an overview of needle steering, and I'll just touch on a few things that we're doing to continue to improve this system. So we have a user interface, so a user actually can control the needle rather than having it move autonomously. I think out of anything in medical robotics, needles, because of their simplicity, are maybe the one thing that can get close to autonomy at the moment. But still, for clinician acceptance and safety and FDA approval, at this point, it really has to be teleoperated. That means a clinician has to be controlling the movement of the needle rather than it doing things by itself. But we can still use these plans and the controllers for our robot at a low level to help the needle go where the clinician wants it to go. Finding needles in medical images is really hard. I talked to a few people beforehand, so I know there's some medical folks in here. And you kind of get what you pay for in medical imaging. MRI is really expensive, but you get beautiful images. Fluoroscopy is not so bad, but you also have ionizing radiation. X-ray isn't so great for people. Ultrasound is our favorite because ultrasound is ubiquitous, it's cheap, but you get what you pay for. You get these grainy images, and it can be very difficult to find little tiny needles in those ultrasound images. And so we're looking at methods to process the images to be able to pull out that information. Yeah, so that and actually being able to find even targets and check for tissue damage are all things that we're interested in. Just one last comment about tissue damage. Remember how I gave that example that you have to spin the needle continuously if you want to go straight? That's not so bad if you have a bevel tip, but if you have a pre-bent tip, it actually kind of cores out the tissue, like, oh, that sounds horrible. And of course, that's not good for tissue, and it causes tissue damage. But if you compare that to what you might have to do if you had to do an open procedure in order to reach the target, then it's less invasive and overall is causing less damage. But we do acknowledge that this technique can cause more damage than just a straight line needle would. But of course, it's doing more than a straight line needle could. All right, so that's needle steering. I'm going to spend a little less time talking about the other topics, but I want to include them for some breadth. So the next topic is haptics for robot-assisted surgery. And first, let me tell you about what classic, well, nowadays, what classic robot-assisted surgery is and where it came from. All right, so we start with open surgery. 30 years ago, this is the way most things were done. The surgeon cut a big hole in the patient, got their big meaty hands in there, and had all sorts of dexterity and tactile, haptic, or touch feedback. And that was, in some ways, good for the clinician in order to be able to do their job, but not so great for the patient. Recovery time was an issue, chance of infection, et cetera. And then minimally invasive surgery, now almost 30 years ago, became very popular for certain types of procedures. The idea being that now, rather than opening up a big hole in the patient, you could create a series of smaller holes, and through one of those holes you would put a camera. And through another pair of holes you might put a couple of manipulators, which are basically long, thin instruments that have grippers on the end. So it's kind of like operating with chopsticks with some grippers on the end. So your dexterity is really limited compared to what you could do with open surgery, but it really decreased recovery time for patients, and in some procedures you could actually potentially get better outcomes because of less collateral damage that you would have from opening up the body. But now, of course, the surgeon is more limited in what they can do. They have to operate through an instrument and camera and are not directly touching the patient. The other thing that can be challenging with this sort of surgery is there's a couple of interesting effects. So you have this camera that's going into the body. If you spin the camera around, usually there's some resident or fellow who's holding that, and either they have to, or they're asked to, or they do it by accident. They might move the camera around or even spin it about its own axis. And then the image that the clinician sees, the surgeon sees, is getting flipped around, and they're trying to see, oh, if I move my hand here, where does the tool in the image go? And this is a very difficult problem, apparently only appropriate for people who have played lots of video games. So this is a difficult. The other thing that happens is you have this long tool, and if you've ever done physics, you're aware of the fulcrum effect. So if you move the end of the tool, the tip is going to actually move in the opposite direction around this entry point that's going into the body. And so that makes it also very difficult to know if I move my hands, where's the tip going to go? So these procedures are not easy to do, and they take a lot of practice and time, and people make mistakes. So enter about 15 years ago, the first clinical surgical robot came in the market. And this is an image of that system. In fact, I'll play a video of it, called the Vinci surgical system, which is a teleoperated, minimally invasive surgical robot. So you're placing those long, thin, handheld instruments with a teleoperated instrument. So the surgeon is moving his or her hands around with these fancy joysticks, and then these instruments here, which are 10 times smaller than the human hand, are following the motions of the surgeon. So it's not a robot in the sense that it has autonomous intelligence or smarts, but it's a robot in the sense that it's a tool, it's a mechanism that sort of transports the surgeon's capabilities to a scale inside the body in a more minimally invasive way. So what we try to do in these sorts of systems is combine the advantages of minimally invasive surgery with those handheld tools with the advantages of open surgery, which is the extra dexterity and also great visualization. The cool thing about this system is it has now a stereo endoscope, so the surgeon actually in their master console gets a beautiful 3D view of what's happening inside the patient environment. That is actually better than what you can do in a regular manual minimally invasive procedure, because the surgeon's sitting at a console where we can automatically, using the computer, align the image that the surgeon sees with the hands. So this can be an advantage. Okay, the disadvantage is now you've got lots of stuff between the surgeon and the patient. You've got a master console, the patient-side robot, the instruments and the cameras, and the surgeon becomes very separated from the patient. And what we do in our lab is we look at lots of ways to try to give this information back to the clinician in a way that will enhance their performance and increase efficacy and patient safety. So this is the big picture of what that particular system looks like. So I was just showing close-up videos of the master and the patient-side robots. This is what it looks like from the outside. So the surgeon sits here at the master console, manipulates those fancy joysticks, has his head in something where he's looking at getting two views, one in each eye, that give him stereo view of what's going on inside the patient. And the robot actually looks horribly big and scary in this picture, but what's actually going into the patient are these tiny instruments which are a centimeter or less in diameter. But there is a lot of infrastructure that has to go into the operating room to be able to hold all of these instruments. So that's the beautiful robot that shows up in the operating room. This is the version in my lab. It's actually the same pieces of that clinical robot. We've collaborated with the company that currently does this as a commercial product. And it has the same stereo vision system, the same master manipulators, and the same patient-side robots, but just in a way where we have access to all the stuff under all that pretty plastic in the commercial version. And it lets us change all the control laws, we can add in graphics, and we can add in haptics, which is a sense of touch. And that's a big challenge for our research lab, is how do you let the surgeon feel as if he or she is touching the tissues directly, rather than there being all of this stuff in between. It's only one of the many challenges, but it's something that interests us a lot. And there's two sides of it, right? If you look back at this picture, there's the surgeon side, and then there's the patient side. And so if you want to give the surgeon this haptic or touch feedback, you have to sense what the forces and tactile sensations are at this side, and then you have to somehow give it back to the surgeon. So there's two sides of it. And the first side here is this haptic sensing. How does the patient-side robot feel, essentially? And you can put sensors on there, but there's all sorts of challenges there. It's not impossible. People have done it. It hasn't always been pretty, but, but people have done it. So one issue is actually on this Da Vinci surgical robot, this particular commercial product, the instruments are actually disposable. They get used about 10 or a dozen times, and then they have to be thrown away and replaced with new instruments. And the instruments, they're not cheap. I like to think of them as the inkjet cartridges of the surgical world. If you have an inkjet printer, you know what I'm talking about. You will more than pay for, many times the cost of your inkjet printer over the years in the cartridges. And there's good reason for that. It's actually, it's very difficult to sterilize the instruments. They've got so many little moving parts. After a while, you don't really want to be reusing them on new patients. And then also, they do wear out just mechanically. It's difficult to make them last forever. So adding sensors to them is something we don't really want to do because of the cost involved in replacing the instruments, and it would make them more expensive. The technique that we use is a control technique. One of the classes I teach here is like an introductory control theory class. And one of the first things that you learn is that if you want to build a controller, to make something move from point A to point B, you give it a command, and it's like you drag it there with a virtual spring. And basically, that's what we also do with our surgical robots. With a master and a slave in our teleoperation system, there's a controller which we program in, which basically creates a virtual spring, so if the master moves this way, the slave or patient-side robot will also follow that motion as if it's being dragged along with by a spring. And ideally, you'd like to make this virtual spring as stiff as possible so it follows as closely as possible. And that's one of the difficulties is being able to do that and have the system remain stable. But back to the haptic feedback side of it, there's two sides of this spring. So if the slave robot is somehow stopped by something, like it's pushing on tissue, then that spring stretches, and then the person who's operating the master can actually feel that force pulling them back. And so effectively, without having an explicit sensor of force, these virtual springs can actually let the human operator feel what's happening on the patient's side. And that's what we do so that we can implement this as inexpensively as possible. So that terrible noise is coming from this video. And what it is the sound, I'm going to turn it off. It's the sound of something going unstable. It's the thing that we do not want to have happen when we're running a surgical robot. And there's this issue, like I mentioned, if we'd like to make that spring as tight as possible, but we can't because of stability. And this is just an example of a simple teleoperator which is going unstable because we've turned up that spring too high. And there's this fundamental control theory that tells us actually that we can only make that spring so stiff or it's going to go unstable. So we have that limitation here. The other thing is, well, you might be wondering, okay, I'm talking about forces, but what about all of the stuff you feel on your skin, like textures and vibrations? That involves a lot of fancy devices. Like here's a little pin array. Well, the pins are little, but the rack of motors underneath to control those pins is big. And ideally, we would like people to feel the actual shape locally on the skin of things that the robot is feeling. We're still very far away from that, but we have some approaches to try to hit this problem. So we're not just feeling forces, but we're also feeling this cutaneous or skin-based sensations. So what are some of the things that we do? Well, here's a robot being teleoperated, and it's palpating, that is, it's pushing on this artificial tissue. And our clinician collaborators, they help us design these fake tasks. In this case, we have a coffee stir straw, which mimics a calcified artery of a patient, which is stuck in this artificial tissue. And then we make it opaque so that the subject in our experiments, we actually do lots of user studies where people come in and try out our devices. They try to see if they can find that coffee stir straw without just by teleoperating the robot, not touching it with their own hands. And so here's someone poking around trying to find that coffee stir straw, and we try out different conditions. We try it out with no haptic feedback. We try this augmented reality graphical overlay bar, which is changing height and color, telling the clinician how much force is being applied. And the clinicians actually really like this idea because they're used to getting lots of visual information. So the ones that we worked with are actually suggested this approach. And then there's actually haptic feedback, applying forces directly to the hands. And so here's an example of the kind of experiment we do and the results that we get, and we're trying to show that haptic feedback could be useful in a task like this. So the goal of the task was for someone to poke around and try to figure out what is the angle of the coffee stir straw. And our subjects, sometimes they're novices, sometimes they're expert Da Vinci surgeons, they show us where they think the coffee stir straw is, and then we measure their error. So of course, low error is good. That means good performance. And then we have these different cases. So that graphical bar I showed you is the graphical case. So you can add haptic or force feedback and graphical together, haptics only, graphical only, and then no force feedback, which is what the current clinical robots have. And then you can see in this plot that the two cases, haptics plus graphics and haptics alone, have much less error than the cases with graphics and then no haptic feedback. And so while people really like the idea of this graphical bar, it actually didn't make any difference in people trying to do this particular sort of haptic exploration task. It seems like people really need to feel something to be able to integrate that information and figure out where things are in the environment. And even even if you have haptics and graphics together over just haptics, it doesn't really improve you a whole lot. So this is an example type of task where it's very useful to have haptic feedback, but the graphical feedback and no feedback are not as good. I'm going to skip the other plot. Here's another example of the type of haptic feedback you could give. So a robot here is actually being teleoperated to push on tissue. And then in this case, rather than trying to give the clinician what is the force they're applying right now, we actually kind of paint over the image, and actually it's done in 3D for the stereo display, how much this tissue, what sort of stiffness the tissue has at any location. And eventually, after they palpate quite a bit, they wind up painting a picture effectively of where a hard tumor is inside the tissue. So that's another approach. I mentioned there's this whole cutaneous aspect about what happens to the skin, and we've played around with this as well. So here's the idea behind this project. If you are holding a stylus like a pen and you're pushing on a surface, of course you feel forces in your muscles that tell you you're applying force. But you also feel a little bit of stretch in your skin where you contact the thing that you're holding. And so we actually decided we were going to enhance force feedback by locally stretching the skin with what we call a tactor. Has anybody here ever used one of these IBM ThinkPad or Lenovo computers with the little red dots that you can use to control your cursor? Well, we actually use those same red dots to move around the skin on the end, on the fingertip, so that the person who's using it actually feels that little bit of skin stretch that would be indicative that they're applying a force. And so here's a video showing a device like this working. So someone's moving around this device, it's recording their motions, and here's a virtual environment where they're palpating and looking for that coffee stir straw in a virtual world. And then there's this red dot here, which normally the finger would be over it, though I had my student take the finger off so that we could actually see it move. See if I can get this to play again. And that red dot is actually moving up and down in its aperture so that if the finger was over it, it would be lightly stretching the skin. And it turns out this is a very effective way to fool people into thinking they're feeling forces, even if they're not. Or if they are feeling forces, we can make them think that they're feeling more force by applying this additional skin stretch. So a lot of the things that we do, they're actually connected to human psychology and neuroscience, because it's really all about these illusions, trying to convince someone that they're feeling something that they're not. And we think this is actually very promising to put into surgical robots. Then my final example for haptics is something that's totally different, just so you can see the wide array of different things that you might do in a haptic system. Rather than a haptic illusion, in this case, we are literally trying to recreate a surface that a person might be able to palpate. Now this is actually more, I'll play this so you can see what it does. What this surface is doing is it's changing its mechanical properties and its geometry somewhat arbitrarily so that you could have different environments that someone would explore. So why would you want to do this? Well, this is more for medical training. So if someone wants to learn how to palpate and actually find, say, a cancerous tumor with surrounding soft tissue, they would want to do this sort of in a hands-on way with multiple fingers. And so we actually need surfaces that can change their mechanical properties so that you have like an active mannequin, and that mannequin can display any sort of training scenario that you might like for your trainee. And so this example is just showing a device like that where we can use, in this case, coffee grounds in silicone cells, which when vacuumed out become hard. So they can be soft or hard, and then we apply air from underneath that can actually make them balloon up. So it allows us to change the mechanical properties and the geometry simultaneously. So very different type of haptic display, and now you've seen a wide range of them. So I'm almost out of time, so I'm just going to very briefly tell you about some of the kind of things that people are interested in using haptics and robotics for in rehabilitation. So I'll just show a few slides about this. So one example, because all the other stuff was more, radiology and surgery. This is more on the rehab end. So one thing that we've done is actually wearable haptic devices. So putting these on the body of a patient and being able to use it to guide their motion. And that can actually be useful because rather than just looking at a screen which engages a patient's visual responses, if they actually feel something, it helps them be more self-aware of their own body. And so researchers have taken these kinds of bands here, which have inside of them little vibrating elements, kind of like the vibrations that come out of your cell phone when it's ringing. And by vibrating on this side or this side, we can tell the patient to move this way or this way. And it's actually helping people recover more quickly and understand their bodies after undergoing a stroke or some other kind of movement problem that results in movement deficit. And we've actually put these all over the body, so you can actually get feedback on how you should move. My student here, shown here, also thought it would be great for yoga training, and so we've had some demonstrations in other domains. Prosthetics is another application area. So how do you actually put sensors under the tips of the fingertips and then feed that information back to the wearer of the prosthesis? And also even as a robot, basically a prosthesis is a robot arm, how do you actually get the brain signals to that arm? So we collaborate with some amazing neuroscientists and electrical engineers here at Stanford who are doing that work. And then finally, let me actually just skip ahead to show an example of a patient who has damage to the cerebellum. So this is a part of the brain that's used in movement control. And he's doing a really simple task where he's trying to touch his nose and then the finger of the clinician who's testing him. And I can do this in a very quickly and make straight line movements. But you can see that his movements are slower and they're also not straight. He kind of overshoots and has to correct. And the neat thing that we can do with robotics is we can actually carefully look at the movements of these patients. So moving in and out in motions like this, compared to a healthy person, you can clearly see that the cerebellar patient isn't moving as well. But by using a robot to collect this quantitative data, we can actually model what is the deficit potentially in the brain that's resulting in these erroneous movements. And then, skipping ahead a little bit, we can actually then use the robot, in this case, to apply forces to the user to actually correct their deficit. So in this case, hypermetria means you overshoot your reaches. Hypometria means you undershoot your reaches. And we can actually use the robot to change the patient's behavior, and before treatment looking like this, and after treatment not having any offset at all. And so the robot is used not only as a treatment method, but as a way of collecting data about the patient so that you can actually come up with an idea about what the right treatment method should be. So that's a quick overview of the things that I talked about. And in particular, if you're interested in learning about haptics, I wanted to just give you a couple links in case you're interested in getting more information about this, because actually this is a big passion of mine, is teaching people about haptic technology. So we've developed these relatively simple, inexpensive haptic devices that anybody, I joke, even a professor, can figure out how to program and control. And so if you or someone you know might be interested in playing with this technology, everything they would need to know to actually build their own haptic device for a total beginner is at this website, hapkit.stanford.edu. And then I don't think I'd be a Stanford professor if I didn't have an online class. So I have an online class at hapticsonline.class.stanford.edu. And right now it's actually a self-paced class because I want the students to try to build their own haptic devices, and it's really hard to put a deadline on that. So if anybody's interested in going online and going through videos and such, this is something that you can do at this website at your own leisure with no deadlines. All right, so I want to thank all of my students and collaborators and the people that give us money for this work, and you for listening. Thank you very much.
For more, please visit us at stanford.edu.